And Dr. Larson, go ahead.
Great. I'm gonna share my screen so we can look at some slides and pictures. Everyone see that okay? Excellent. All right. So thank you for letting me talk to you all this afternoon. I think these support groups are one of the most important resources and important things that patients and caregivers can participate in. So I think it's great that you guys have this get together. What I thought I would talk about just at the beginning of the time together today is just a little bit sort of an update on the surgeries that we do for Parkinson's. Specifically, we're going to talk about deep brain stimulation, since that's really still the gold standard of what we do. But I'm going to talk a bit about what's new and some things that are coming, and then we'll leave plenty of time at the end for questions. So many of you probably already know about deep brain stimulation, although some people may be new to this idea. So deep brain stimulation is a surgical technique, and the easiest way to think about it, it's like a pacemaker for your brain. It's an implanted device. There's a battery pack that sits underneath the skin in the chest, underneath the collarbone, and that is connected to one or two wires that run underneath the skin, sort of up along the side of the neck, behind the ear, up to the top of the head, and then down through the skull into the brain. And what we're doing is we're stimulating a particular part of the brain that's involved in your movement, and it's a part of the brain that's affected by Parkinson's disease. And what we believe it's doing is we think it's interrupting the abnormal activity in that motor circuit in the brain, and it subsequently can make the symptoms of Parkinson's better. It doesn't make all the symptoms better, and we'll talk about that in a little bit. So these are some skull X-rays of what this device looks like. So you can see there are two electrodes. There's on your left is a front view, so there's one on the right, one on the left. And they go pretty far down into the brain. This is called deep brain stimulation for a reason. These structures that control our movements are quite a ways down into the brain. And then the
Dr.
wires.
Larson,
Yes.
we're not seeing that slide.
You're not.
Yeah, could you click on the play?
Well, there's no. What are you seeing right now? You're just seeing me?
We're seeing your first slide. That's an introduction.
Oh, interesting.
Title.
That's very interesting. I'm going to stop and let me try it again. All right, so you see my title slide,
right?
You see a picture now or no?
We're just seeing the title slide, and this is your, okay, now it advanced.
Yeah, I wonder why that's not actually playing. I'm going to stop the share for a second. Okay. And let me try it a different way. The joys of Zoom never stop. Let's see. Let's keynote. Yeah, it's funny, I don't actually see my desktop, which is interesting. Okay, let me try it one more. Let me try it one more time. What do you see now?
We're seeing the second slide.
Yeah, okay. Maybe, so for some reason, it's not actually playing the slide deck. So what I could do is we could, if you don't mind seeing all this other junk, we could just do it like this. Maybe that's the best way to keep moving forward. How's that sound?
Sounds okay.
Okay. Let me see if I can put some of this stuff out of the way. There we go. Makes it a little bigger anyway. All right. So, so here are some skull X-rays of a patient that has had deep brain stimulation. So there are two electrodes in the brain, one on the right, one on the left. And again, everything is internalized. Everything is on the inside of the brain. So there's no wires that are sticking out or hanging out of the body. That's a common question that we get asked. And when we look at the business end of these electrodes, so this is the part of the electrode that is in the brain. This is sort of a schematic view of what that looks like. So this sort of yellow almond shaped structure is a part of the brain that we often stimulate in Parkinson's. It's called the STN, or the subthalamic nucleus. And you'll see that the stimulating electrode has these 4 metal surfaces. They're made of platinum, and this is where the stimulation comes from. And so there are 4 little rings on the ends of these electrodes, and we can stimulate around any one of these rings individually. So we can change the location within the STN, or whatever target we want to stimulate. We can sort of have them on individually to stimulate different areas of the target. We can have several of them on at once. So we can have 2 or 3 on simultaneously, and that stimulates a larger area. We can turn up what we call the amplitude of stimulation. That's the same way as thinking about the volume of stimulation, and that makes these areas bigger. So we're stimulating more tissue. And if we turn the device off, it's like it's not there. So it's like all the effects of the stimulation have stopped, and it's like you've never had anything done. So it's what we call an adjustable and reversible therapy. Now, in the old days, which was not that long ago, we used to do these surgeries with patients awake for part of their procedure. So we would apply a metal frame to the head, and this allowed us to make a 3-dimensional map of the brain. It also rigidly held the head in place, and we could put electrodes in. And what we would do in the old days is we would turn the electrode on and have the patient awake, so we could take a look at their tremor, for example, or their stiffness, and make sure that their symptoms were getting better. And if the symptoms were getting better, we knew we were in the right spot. So here's an example of that. So hopefully you can see that video playing. This is a gentleman with pretty bad tremor. He's awake, as you can tell. I'm behind him. We've got an electrode in his brain. We're going to turn that electrode on. We're going to turn the amount of stimulation up, and we're going to see his tremor get better, just sort of right on the spot. So this is the nice thing about deep brain stimulation. For symptoms like tremor, the effects are quite immediate. This is also true of the stiffness or the rigidity that we see in Parkinson's. There are other symptoms that take longer. They can take minutes or hours of stimulation to really make better. And these are things like slowness of movement, for example. But this is what we used to call awake surgery. And there are still places today that use awake surgery. As you might imagine, it's a little intimidating to think about undergoing your brain surgery while you're awake. It can be difficult for some patients. And the procedures tended to take longer. They could take 6 or 8 hours to perform these operations with this awake technique. So about almost 20 years ago now, when I was in San Francisco, we developed a way of doing these procedures inside of an MRI scanner. And what this allowed us to do is it allows us to actually see inside the brain during surgery. And these areas that we want to stimulate in Parkinson's disease, like the subthalamic nucleus, for example, that little yellow circle we saw a couple of slides ago, you can actually see that on MR imaging. And so we got rid of that big, bulky frame that we used to bolt people's heads. We developed a skull-mounted aiming device. So it's a little plastic aiming device that just temporarily mounts on the head. And we can get MR images of this device while it's mounted on the head, and we can align this device with whatever target we want to implant. And we can get real-time MR pictures throughout the procedure as we're doing that to make sure that the electrode is going where we want it to go. And this eliminates the need for us to do these procedures awake. So deep brain stimulation across many centers in the United States has really evolved towards this idea of a sleep surgery or a sleep DBS. And this is really the biggest advancement in the way we do these surgeries in the last 20 years. And it's really now the technique of choice in Arizona. So we do this exclusively at the University of Arizona Banner. There are several centers in Phoenix. There's a Banner University of Arizona Phoenix campus, and there's a surgeon there, Dr. Bina, that does these this way, also does a little bit of awake surgery. And then the Barrow Neurological Institute in Phoenix also does a sleep surgery. They use CAT scan instead of MRI, but the concept is essentially the same, and that's Dr. Fran Ponce. So we can take a patient with Parkinson's that looks like this, that's very stiff. This will be a video that's many of you will be familiar with. Difficult for this lady to stand. I should say that our patients give us permission to show these videos. So if you come and see us, we're not going to automatically put you up on YouTube. We only do this with very, very specific and strict permissions from the patients. But you can see she's very slow. She has tremor. She just really can't start moving. We're asking her to take a couple of steps, and she's really sort of frozen in place. So we can take someone like that, and we can make them look, this is about 3 months or so after deep brain stimulation, and we can make them look a lot better. We don't make people perfect. You'll see when she turns here, she has a little bit of an instability there. She still has a little bit of stiffness to her walking, but in general, we can make symptoms significantly better. And specifically, we can make 5 symptoms better. Tremor, if you have tremor, we can make that about 90-something% better. Slowness of movement, that gets about 80 to 90% better. Stiffness, we call it rigidity in the medical field, but stiffness, muscle stiffness, we make that better. Walking troubles, particularly shuffling when you walk, that gets better. And then finally, if you have dyskinesias, which are these sort of involuntary movements, we can make those better as well. So how do we decide who's a good candidate for this? This has also evolved over the years. And when I started doing deep brain stimulation in the late 90s. It was FDA approved in 1997, and that's about when I started doing it. We really didn't understand how to pick patients. If you had Parkinson's and your medications weren't working particularly well, and you showed up at our doorstep and you were willing to have surgery, we did it on you. And the intent was to try to make people better. And most people got better, but some people didn't. And so we've learned over the last decade, 2.5 decades, how to sort of properly select patients. And if you properly select patients, they almost always show improvement. And I want to just talk for a couple of minutes about how we do that, who makes a good candidate. And one important aspect of this is the confidence in the diagnosis. How do we, are we really sure this patient has Parkinson's disease? And that may seem like a silly thing to say, but there are many other neurologic disorders that look like Parkinson's. Patients have tremor, they have slowness of movement, they have stiffness. But there are other features that aren't typical of Parkinson's, and they tend to not improve with the Parkinson's medications. So these other diseases are things like progressive supranuclear palsy or multi-systems atrophy. These are not nearly as common a household name as Parkinson's disease, but there are other much rarer, fortunately, neurological problems that look like Parkinson's, but really aren't. And it's important for us to try to tease that out, because if you have garden variety Parkinson's disease, DBS usually helps. And if you have one of these other disorders, it almost never does. And we don't want to put someone through an operation that doesn't work. So how do we tell if patients really have sort of garden variety Parkinson's? This is tricky. There's a particular kind of brain scan called a DAT or DAT scan. Neurologists in Tucson do like to use that test. And it is abnormal if you have Parkinson's disease. It shows a decrease in essentially dopamine in a certain part of the brain. The problem is there are other diseases that have that similar appearance. So it's not anywhere close to 100%. It's maybe 70% accurate for really diagnosing Parkinson's. But we'll see patients that have an abnormal DAT scan and they're told, well, you have Parkinson's. And that's only true, a little less than 3/4 of the time, or maybe 70% or so of the time. So how do we really tell? Well, one of the things that we do is if you have a clear improvement with Sinemet or carbidopa-levodopa, which is the most common Parkinson's medication that we use, that is a very good indicator that you really have Parkinson's disease. And so one of the things that we do if someone comes to us and they're interested in deep brain stimulation is we do one of these tests. We have them hold their medications, whether it be carbidopa-levodopa or whatever medications they're on. We have them not take that at least overnight. So we have them skip their morning dose, so they're off their meds for at least 12 hours. Usually the symptoms are worse since they're off their medications. We have one of our neurologists or one of our nurse practitioners do an examination, and we kind of give them a score of how severe their symptoms are. And then we have them take their medications and just wait around in the office until they feel like their medicines have sort of kicked in, and we retest them. And we look for at least a 30% improvement in that off medication score versus that on medication score. And that's a very good indicator that someone really has Parkinson's. And it's a very good indicator that DBS surgery would be helpful. Now, interestingly, the one exception to this is tremor. So there are some patients with Parkinson's that have tremor that just does not respond to medications, yet it may respond to deep brain stimulation. So that's the one exception to this test. The other thing we ask patients is, what do you feel like when your medications are working their very best, even if it's just for a few minutes at a time, just intermittently throughout the day, or maybe just once a day. But when everything is perfect and the medications are working their very best, how do they feel? And the reason we ask this question is that deep brain stimulation, it really can't make people much better than they are when they're in their best on medication state. So when I talk to a patient, we love to hear, well, geez, when my medications are working well, I feel really good. I feel normal almost. But when my medications wear off, I really have trouble getting around. My tremor is bad, my movements are bad, my walking is bad. And then they take their meds again a couple hours later, and then they're good again. So they fluctuate. They have fluctuate between good on periods and bad or off periods throughout the day. Early on in Parkinson's, the medications for many people keep them pretty steady throughout the day. And if your meds are working very well and you're very consistently good throughout the day, it doesn't make sense to do surgery in that patient at that time, because we're not going to make them any better than that. But as their disease progresses, as the years go by and the medications become less effective and they start to fluctuate, that's the time to think about surgery. So again, these are the 5 symptoms that DBS really helps: tremor, rigidity or stiffness. Bradykinesia is a medical term for slowness of movement, and that includes freezing, walking problems, and then again, these dyskinesias. These are these involuntary kind of wiggling movements. If you've seen video of Michael J. Fox, he's a very good example of what a dyskinesia looks like. Now, it doesn't help a lot of other symptoms. So we all know that there are what we call non-motor or non-movement symptoms of Parkinson's. These are things like memory troubles or constipation or getting lightheaded when you stand up or your voice getting soft. These are all examples of non-motor symptoms. They tend to not improve with medications, and they tend to not improve with DBS, and that includes sleep as well. Sleep troubles are super, super common in Parkinson's disease, very difficult to treat those. I touched on this a minute ago, but there's definitely a window of opportunity where it makes sense to do deep brain stimulation. If you were just diagnosed 6 months or a year or 2 years ago and your medications are working really well throughout the day, it doesn't make sense to do surgery in patients like that. They have good function. We're not going to make them better than that. And there are some risks of doing this operation, which we'll talk about in a little bit. And you know, God forbid, if you have a complication, it's actually going to make you worse. So there's really no upside to doing surgery very early, and there's risk associated with it. Similarly, if you wait very, very late stages of Parkinson's where nothing is effective anymore, the medications don't work, DBS can't sort of rescue you from that very late stage Parkinson's. If the meds don't work anymore, the stimulation won't work anymore either. So it's this middle part of the Parkinson's journey that patients go through, where the meds are starting to become less effective, you're starting to have those fluctuations, or the medications are causing those dyskinesias. That's the time to think about doing surgery, and it's the time when surgery makes the most sense. So I touched on the fact that, you know, memory troubles or cognitive troubles are very common in Parkinson's disease. This slide says dementia is very common. It's true, although most people with Parkinson's have not dementia, but they have what we call mild cognitive impairment. And if you have no memory troubles, or if you have mild memory troubles, surgery will not make them worse. It's not going to make them better, but it usually does not make them worse. Now, if you have more severe cognitive impairment, or if you really do have memory troubles that are so bad that it puts you in the category of having a dementia, then surgery can permanently worsen that. So if people have mild memory issues, it doesn't preclude us from doing surgery. And in fact, most of our patients have some degree of memory or cognitive troubles, just it's part of their Parkinson's disease. But if the memory troubles are really significant, we will make that permanently worse. Not only can we just make it worse, but it's very difficult to manage those patients after surgery. When we put these systems into patients, we have to adjust the settings. We have to either increase or decrease the amount of stimulation, change the area where we're stimulating. And we do that to optimize the improvement. And we want to minimize stimulating adjacent structures. There are other parts of the brain next to these Parkinson's areas that do things. And if we spread stimulation into those other areas, we can do things like affect your speech, make your speech a little slurry or hard to get the words out. Or you might feel a little tingling in the part of the body, the face or the arm. And we can get rid of those side effects by decreasing the stimulation. But we're very dependent on patients being able to tell us what they're feeling, how they're doing. And if you have really significant memory troubles, it's hard for patients to give us feedback, tell us really what's going on. And if they can't give us feedback, we're really in the dark. So dementia or significant cognitive issues are really do preclude us from doing surgery in some patients. Age is a really common question. There are some centers that set sort of hard limits on, well, we are not going to do surgery on someone no matter how good they look or no matter how good a candidate they are if they're over the age of 80 or 75 even. We don't believe in that. And actually, I saw 4 new patients yesterday in my clinic, and 2 of them were over 80. One of them was 84. Probably by the time he has surgery, he's going to be 85. And there was another patient that had surgery when he was 82 on one side, and he's now coming back for the other side. He's going to be 84. So age as a number is not really what is important. There is one important thing to keep in mind, though. However, the response to stimulation tends to be more robust the younger you are. So, you know, an 82-year-old will get improvement in their symptoms, but it's not going to be as dramatic as a 42-year-old, for example. Finally, I think a very important thing is making sure that we communicate to patients, what are the expectations? What is this really going to do for you? And a lot of people expect miracles, or they want to be not just normal, but they want to feel like they were, 30 years old again. And DBS really can't do that. It doesn't make people 100% better 100% of the time. It's a complicated therapy. You have to come in to have adjustments to the stimulation periodically for the remainder of your life, essentially. And it's very important to keep in mind that this is not a cure. It does not cure Parkinson's, and it doesn't stop it from slowly getting worse as the years go on. So I alluded to this earlier. There are risks of doing surgery. The two big ones, we can cause bleeding in the brain as we're putting the electrodes in. And the risk of this, there are some patients that get a very small amount of bleeding that we can detect on the MRI scan during the surgery, but it's such a small amount of bleeding, it actually doesn't cause symptoms. But the risk of actually causing a hemorrhage that's large enough to cause symptoms, it's a little less than 1%. We tell people 1% just to make it easy. So one patient out of 100 will have stroke-like symptoms because of bleeding in the brain as we put the electrode in. And these could be things like weakness on one side of the body. It could be speech difficulty. It could be comprehension difficulties. It could be trouble with memory, could be seizures. These things might be temporary and get better with time and therapy, or they could be permanent. So again, this is why we don't do surgery in patients who are very early or just diagnosed, and patients in whom medications are working well, throughout the day. A more common problem is actually infection. We're opening up the body and putting a battery and wires inside. And so there's about a 3 to 4% risk of infection. And this is higher in patients that have things like diabetes, for example, which makes your immune system not as strong. Sometimes patients are taking medications. For example, if you have some forms of arthritis, or if you have bad lung issues, you might be on medications called steroid medications. These are medications that suppress the immune system, and it can help keep your lungs and your joints from being inflamed, but it can increase your risk for having surgery in general. So that's something else to think about. And when we have patients come in, we look at all the other medical troubles they have, and we make sure that we take those into account when we're having a discussion about what the risks are. There's always a chance that people just will not improve. Again, this has gotten much better over the years, but every now and then, despite our best efforts, we implant somebody that we think has got garden variety Parkinson's, and they don't get better, and lo and behold, they end up having something else. And this last point is actually a very interesting one. So we've known for a long time that if you don't get the electrodes in the right spot, the symptoms are not going to improve. And for patients that are implanted elsewhere and come and see us because they're not doing well, the first thing that we check is we check a scan. We get an MRI scan to see where are the electrodes. And we tried to sort of get a handle on this a couple of years ago. Centers that are very experienced that tend to publish their results tend to be centers that are very experienced, and they're very good at doing this. And so their rates of getting electrodes into the, not the best spot are very low. It's probably less than 2%. At our center, it was less than 1%. So it's a very rare event. There are some hospitals, however, that do DBS, and they're just not as experienced, or they don't do it very frequently. And their rates of electrodes not ending up in the right place is higher. The problem is they tend to not report that, right? So we looked at, there are national databases of surgery. So if you have surgery for any reason, a knee replacement or a hip replacement, or you have your gallbladder taken out, those surgeries get reported to the Medicare database and another database. And we looked at those databases to try to find patients that had had DBS surgery. And then at some point afterwards, they had had a revision surgery, another surgery to move the electrode or do something with the electrode. And what we found in these databases, and we looked at over 28,000 procedures over an almost 10-year period, we found that upwards of 15% of surgeries ended up in electrodes that needed to be moved at some point down the road. And one of the databases we looked at, that number was even higher. So this is an interesting phenomenon. We don't really know what this true number is, but I think the point of this is if you're thinking about having DBS, you should go to an experience center that does it frequently and regularly. And the good thing is in Arizona, there's plenty of options in Tucson and in Phoenix. Now, I'm going to move into just the last part of the slides here before we take some questions. We're going to talk about some new innovations that are happening. And these are innovations that are making DBS safer, and they're making it more effective. And one very interesting innovation is the ability to direct the electrical stimulation within these brain structures of like from one side to the other, instead of stimulating like a light bulb in the middle of the room and the lamp the light fills the whole room evenly in all directions, which is the way we usually do stimulation. We can direct stimulation more into one part of the room or the other. And this allows us to minimize stimulation of these structures that are adjacent to or next to the Parkinson's area. So I'll show you some concrete examples. So here's a DBS electrode. We're going to put it in a target. So this orange thing is the brain target. And these new electrodes, what they've done is they've gone from having 4 stimulating surfaces to having multiple stimulating surfaces. So in one example, an electrode that's made by Boston Scientific, they have actually 8 electrodes along their stimulation DBS system instead of just 4. And they're spread over a wider area. So if the electrode is positioned like this in the target, we can stimulate within the target. And each of the rings can be individually programmed. So you can have some of them at a higher amplitude or a higher volume, if you will, of stimulation. So you can see this one in the middle is turned up higher. So it's stimulating a larger area. The electrodes or the little rings that are near the edges, we turn them down so you can sort of shape the stimulation vertically. If this electrode happens to be a little bit deeper, let's say that the surgeon put it a little bit deeper, and this just might be a millimeter difference in depth, but that can make a big difference in how we stimulate. We can just simply use these upper electrodes. So this is a wider spaced electrode array, if you will, and that allows us to direct current up and down. Most of the time, however, we have problems if the electrodes are not exactly in the middle of the target and they're either a little bit in front or back, or they're a little bit one side to the other within the target. So let's look at an example of that. So we're going to look sort of top down. So again, this yellow structure, that's what we want to stimulate. The lead is the stimulating electrode, and this black ring is that metal ring that we're stimulating. And so this is what historically we've done. The stimulation, it encircles the electrode, so it's spreading evenly in all directions. And if the lead is right in the middle of the target, we're in good shape. Let's say though that the position is a little bit off to one side. We're still in the target, but when we turn this electrode on, we're spreading this red area of stimulation outside the intended area, this orange thing. So these green arrows, that's electrical current or stimulation that's going outside of the intended target. And that can cause side effects. It can cause speech troubles, for example, or it might cause a little bit of tingling, as we talked about earlier. So what Boston Scientific has done, and now the other companies have followed suit, is they've taken this ring and they split it into 3 parts. So there's 3 stimulating surfaces. We call this a segmented lead. And what it allows us to do, you can turn on one of these segments at a time. So you can just turn that segment and that segment on, and you can direct stimulation to the middle of the target, and you can leave this outer ring or this outer segment of the ring off. So you're not spreading stimulation outside the target. So this is what we call lateral current steering. And it's really revolutionizing the way that we think about stimulating these targets. And all three of the companies now that make DBS systems, Boston Scientific, Abbott, and Medtronic, all now have these segmented leads, or they call them directional leads. And if you have DBS now, this is what you're going to get. Now, this is very new. I mean, 2 years ago, we didn't have any of this stuff. So the technology is really evolving very rapidly. I'm going to talk about one last thing, and then I'm going to stop, because no one should listen to a lecture for more than 40 minutes. But, what's the future? And we believe the future is this concept of what we call closed loop stimulation. So let me explain what that means. These systems currently are like little soldiers. We give them instructions. We tell the little battery pack in the chest, we want you to stimulate at this frequency, in this location, and at this amplitude or this volume. And that's what it does. And it doesn't alter itself. It just does that 24/7. And those settings won't be changed, or won't change, unless either the patient or the doctor uses a little programming device to wirelessly change the settings. It would be nice if these devices could sense your brain activity and adjust the stimulation automatically. For example, in Parkinson's disease, we stimulate continuously. We know that if we stop stimulation over the course of minutes or hours, symptoms will come back. And when you turn the stimulation back on, symptoms like tremor and stiffness get better pretty quickly, but slowness of movement may take another couple of hours to really fully get back to normal. And so if we have people turn their stimulators off at night when they're sleeping, when they wake up in the morning, they're going to feel pretty bad. And if they turn their stimulators on in the morning, it's going to take them hours to kind of really get up to full benefit. We don't want that to happen. So we just leave them on all the time. But we probably don't need to be stimulating people full strength while they're sleeping. We probably could dial back the stimulation a little bit. That could save battery life. It could make the stimulation during the day when patients are awake more effective. So my partner in San Francisco, Phil Starr, who's still there, is just one of the world's best DBS surgeons, came up with this really intriguing idea. He put the regular stimulating electrodes down into the brain, but he put a third electrode on the surface of the brain. And he used this electrode to sense the brain activity over the part of the brain that also controls our movements. And he's made some very interesting discoveries. And one of them is he can tell just by doing brain recordings if someone is having dyskinesia. So this is kind of a complicated slide, but these little squiggly lines are just sort of frequency of brain activity. And the blue line is the brain activity when someone's having a dyskinesia. And the orange line is the brain activity when someone's not having dyskinesia. And you can see that if the patient's having dyskinesia, there's this very obvious spike in activity at a very specific brain wave frequency. And it's just not there if the patient's not having dyskinesia. So he used this to alter stimulation when the stimulator sensed that the patient was having dyskinesia. And you can actually more effectively treat dyskinesia if you change the stimulation parameters slightly. So this is an idea or a concept called sensing, brain sensing, and it is coming. The Medtronic DBS system actually has this capability now. The others, it's coming. We don't exactly know how to use this to our best advantage yet, but this really is the future. The next 5 years or so, I think, are going to see some really remarkable advancements in this sensing technology. And I think it's going to make these systems even more effective. All right, that's the end of my slides. I'm going to stop sharing. And I think we lost Charlene, our host. I don't know did someone take over being the host?
Yes, that would be me. I'm Cindy White.
Maybe not. Okay.
Muting myself. So I told people
It's going to be hard. So let's see. Let me see if someone wrote anything in the chat. Oh, okay. So no questions in the chat. So does anyone have any questions? If you want to ask a question, just unmute yourself and I will answer it for you. And it's Friday afternoon, so if no one has any questions, we'll chalk it up to a Friday.
I do, Dr. Larson. Can you hear me? Can you hear me, Dr. Larson? No. He can't hear me.
I can
All
hear.
right. Doesn't look like we have any questions.
No.
Michelle is waving his hand. Do you know how to unmute yourself?
I have a question also.
Okay, so if you have a question, you need to
Looks
unmute.
like you did it.
Right, we did it.
There.
I did it.
Well, my son did it.
Well, we still can't hear you.
Well, I can, Dr. Larson, I can hear her.
Yeah, I
So-
think when we lost Charlene, we might have lost the ability. She may have the only ability to unmute everybody.
so I
Let's
think-
see. She said someone else was going to be taking over, but I don't see.
Actually, that's
I don't see
me.
anybody else. So Michelle, I can see you're unmuted, but we still can't hear you. And I think it's because when we lost Charlene, I think she has to be the one to unmute you. Oh, here's something in the chat.
Here I am.
Here, let me, how do I put something?
Okay, I see my mother has, but that's all I see. I'll let you type.
I click on that.
That's me.
Where do I type? Here?
We're unmuted, aren't we?
You are.
Okay, so Jose, got a couple of questions. So Jose is asking, how long does the operation last? So that's a very good question. It depends a bit on, number one, who's doing it, and secondly, what technique they're using. So so I can answer that for myself. I use a system called ClearPoint. That is the system that uses MRI guidance. And it's to put bilateral, that's electrodes in both sides. It takes about 3 hours. Now it's a two-step process. We put the brain electrodes in on one day.
Right
You
there.
spend overnight in the hospital. And then a week or two later, you come back for about a 30-minute outpatient procedure to put a second pair of wires that connect the brain wires down to the battery pack. That takes about 35 minutes. Now, everyone works at their own pace. So there are people that use that system that can take 6 hours to do it. Just the workflow that I use, it's 3 hours. So that was Jose. So Michelle, my mother has blepharospasms and is blind from her Parkinson's, a very rare case. That is very rare. Will this potentially help her? So for people that don't know, blepharospasm is a forced closing of the eyelids. And it's actually a form of, it's a symptom we call dystonia. So I can, Michelle, I can see you, so you don't have to type, but is your blindness because the eyes are constantly shut, or are you blind even when your eyes are open?
They're shut.
When your eyes are shut?
Yes.
Okay.
I didn't.
Looks like, so blepharospasm can improve with deep brain stimulation. There's a particular type of dystonia. It's called orofacial dystonia. People can get forced eye closure, and DBS can help with that. It's not as sure a thing as some of the other symptoms, but yes, we've had a number of people where they just can't keep their eyes open, and it does help. So come see us.
Yes.
Let's see, Mike, do we need a referral to make an appointment with you? That's a good question. It depends on your insurance. Generally speaking, we'll see anybody, happy to see anybody. So what I'll do is I'll make sure that I get Charlene our number to if anyone's interested. Just calling Banner can be a bit daunting.
No kidding.
We're trying to fix that, but I can get the number to her and she can circulate it to the group. Let's see. Angela is asking how long do the batteries last?
For you?
And my husband had a loop the DBS. I'm not heart with the heart loop.
Yes.
With the heart loop for monitoring only, would that preclude him from DBS? So so let me answer the first question first. So the batteries, there's two types of batteries. There are non-rechargeable batteries. And like the name says, these are batteries that you don't need or you can't recharge them. So they're just, they run until they run out. Those actually last about 3, maybe 4 years. The companies will tell you they last 5 years. It's not true for the most part. It's 3 years is more typical. The advantage of a non-rechargeable battery is that you just don't have to think about it on a daily basis. It just does its thing, and you just periodically can check the battery, or your neurologist can check the battery. And when it gets close to running out, we have you come in and we do about a 15-minute outpatient procedure to replace it. Then there are rechargeable batteries. So Boston Scientific and Medtronic make rechargeable batteries. These you can wirelessly recharge them through the skin. And if you keep them properly charged, they will last for 15 years before they need to be replaced. They also tend to be smaller. So if you're very thin, they're a little less bulky when they sit in the chest. The disadvantage of a rechargeable battery is that you have to recharge it. So, you have to remember to recharge it. You have to take the time to do that. I will tell you, the Medtronic rechargeable battery, we recommend people recharge it a little bit every day or every other day, which some people find a little annoying. The Boston Scientific is the best rechargeable system on the market right now. It's a little small. It's the smallest battery pack we have at the moment. And the recharging system, I think it's a bit easier to use. You only really have to recharge maybe once or twice a week. The second question, I'm not sure what a heart loop is, but I think what you might be referring to is a heart pacemaker.
No.
And pacemakers can be challenging. Some pacemakers are okay to undergo an MRI scan. Some other pacemakers, however, you really can't get an MRI with that in place. And if you can't get an MRI, you really can't do this surgery. You can get a CAT scan of the brain, but CAT scans do not show enough of the brain detail for us to safely do these surgeries. So pacemakers, that's the one thing that we do have a problem with, and it occasionally does sort of preclude someone from these current therapies. It's not a pacemaker. So she put something else in. It's not a pacemaker. It is to monitor PVCs. So if it's an external device that you can take off, then it's not an issue. I'm not familiar with, I'm not a cardiology person, so I'm not sure what a heart loop is. I apologize for that.
Yes.
I have another
All
question.
right.
Dr. Larson.
And I saw someone else took over as the host. I saw a little thing pop up, but I don't know who that is.
Dr. Larson, can you hear me? Can you hear me, Dr. No.
If anyone has any other questions, though, feel free to pop them in the chat. And I can actually, while I'm thinking about it, I can put the referral number for our clinic in the chat. If people want to see that, maybe that's a good thing to do. I have to look it up. I do not have that committed to memory. I probably should. So I will put this in, and there's, whoops. Okay, so one of them is a fax number, which is what your doctor's office would need. So if you're a neurologist, most people that have Parkinson's are seeing a neurologist. And so that's the fax number. It is super helpful to see records before, just to make sure that we know what's been tried and what's coming down the pike. So okay, someone said, Michelle says we can hear the other members. Yeah, I can't hear anybody. Since we lost our host, I can't hear any of you. And then Angela said she's back on this heart loop thing. She says it's implanted. So we would just have to figure out what that device is, if it's safe to have an MRI with that device. The bottom line is if you have an implanted device and the manufacturer says it's okay to have an MRI scan, then we can do surgery. If we can't get an MRI scan, then we're stuck.
I won't ask him anymore.
There is a question in the chat box.
Tom asked a great question. Can the leads be upgraded when new improvements are found? This is an excellent question. So there's really two ways to think about these systems. There's the electronics part of the system, which is in the battery pack of the chest. And then there are the leads, which are the parts that are actually in the brain itself. These new battery packs that contain these stimulating electronics, you can do firmware upgrades on them. So you can upgrade the software. And if there are new stimulation paradigms or stimulation patterns that people discover, or sensing capabilities, you can upgrade the software. But the stuff that's implanted in the brain, the only way to upgrade that is to take the old hardware out and put new hardware in. And it's interesting, most up until just a few years ago, maybe a little over 2 years ago, we did not have these directional leads, for example. We had just the leads that would stimulate concentrically in all directions. And the reality is, if you get an electrode in a good spot and it's programmed, the settings are programmed correctly, so your neurologist knows what they're doing, and the settings are just what they need to be. In that scenario, we really don't need to rely on directional stimulation. It's only if electrodes are a little off center, a little too close to an adjacent structure that might cause some side effects. That's when we really use directional stimulation. So when directional electrodes came out, I thought we might be swapping leads out. We haven't really done that yet. We certainly use directional leads with all new implants, but I haven't had a situation yet where we've swapped the leads out. But Tom, to answer your question, the only way to upgrade the leads is to physically change them, and that's another brain operation, which you'd have to think about that pretty seriously. Let's see. Cindy says, please see question and chat from Bob Kiesel. So maybe I missed it. Let me go back up. Bob Kiesel. Oh, yeah, I did miss this one. Oh, yeah. Oh, this is a good question too. So does gait include balance, and does dyskinesia include tardive dyskinesia? Really great question. So balance issues are very common in Parkinson's, and balance is a very complicated issue. Some people have balance problems because they shuffle when they walk and they can't move their feet quickly enough to maintain their balance. So what I tell people is, if their balance troubles are worse or only present when their medications are not working well, and the balance issues go away when their medications are working well, then it should get better with DBS. Some people, however, have balance issues just because their balance is bad, and their balance is bad. It doesn't matter if their meds are working well or not working well. And in those instances, DBS really doesn't help balance. So balance and another issue called freezing of gait. Some people that they just freeze when they try to walk. Some of those patients respond well to DBS and others don't. So those are two really big issues that we don't have a great answer for yet. The other question that Bob had, so does dyskinesia include tardive dyskinesia? So tardive dyskinesia is a dyskinesia it can be a side effect of taking certain medications, and that does get better with stimulation. In fact, sometimes people will be on a medication like Abilify, which is a common medication that can be used for some psychiatric disorders or mood disorders, and it can cause abnormal movements. And we can help that type of dyskinesia with DBS. So, Bob, I'm sorry I missed that. Those are good questions. All right, we're getting close to the bottom of the hour. I don't know if anyone wants to squeak one more in, or if we're good on a Friday. Jose is looking content. He's looking content. He looks like he's ready for margaritas.
What do you want to ask?
All right. Very good. Well, listen, I want to thank everybody. I'm sorry for the technical issues. I don't know why my slides weren't playing, but hopefully we made the best of it. And happy to come back. We're going to be, just so the group knows, we're going to be starting some exciting new clinical trials for Parkinson's. One of the things that brought me to Arizona was to come and do some new therapies. DBS is great, but we're looking for biologic treatments that might be solutions. These are things like stem cell transplants and or a technique called gene therapy. And we're going to be starting some of these trials. So one of them is starting. There's a lead-in trial that's actually starting next month. So maybe later this year or in the fall or this time next year, we should get back together and we can talk about some of those as options as well. So thanks, everybody. Have a great weekend, and we'll hopefully see you soon. All right. Okay. All right. Bye-bye, everybody.